accept change. And if change is for the better, it's always welcome. Good morning, ladies and gentlemen. I, Swapnil Kumar, welcome you all to Advanced Cataract and Refractive Symposium. We have assembled here to witness a breakthrough change which has happened in not only Phaco machine but in intraocular lenses for the better. In next few hours, I am sure all of us would be watching the great performance by our esteemed faculties and absolute legends in the Ophthalmology Society. They will be taking 6-7 surgeries today along with short inaugurations and a talk around 10:30 a.m. To make the session even more interactive, we have sets of esteemed moderators and panel today. We have two moderators among us, the most dynamic ophthalmologists of our state, Secretary of BOS, DDA, IGIMS and Chief of RIO, Professor Vibhuti Sinha, to moderate first two sessions, and ever-smiling treasurer of BOS and in charge of I Bank of RIO, Professor Nilesh Mohan, for the next two sessions. And I would like to hand over the mic to Professor Vibhuti Sinha sir to start the proceeding.
So now we start with today's proceeding. First of all, I'd like to congratulate WSD for this achievement, for serving so long the state of Bihar, the patients of Bihar, and providing them with the best of eye care. I also congratulate all those invitees who are present today and participating even from distance. Let me invite the panelists today for the first session. Dr. Ranjan, please come on the dais. Dr. Ranjan is a dynamic surgeon, pass out of All India Institute of Medical Sciences, and a prolific cataract surgeon. Dr. Sujit Mishra, ever smiling with the flute. Dr. Vishal Kishore, and Dr. Abhishek Kesha. So there is a slight change in today's proceeding. First we will have the surgical session and surgical light surgery, and then we will have the talk of Dr. Professor Rajesh Sinha. So over to Dr. Ranjan with your quizzing questions during the light surgery. Please proceed, sir. Dr. Nagendra, sir. And Dr. Abhishek, can you elaborate on the patient on which we are operating today? Dr. Abhishek from OT, Operation Theatre. Dr. Abhishek from Operation Theatre. Yeah, please elaborate upon the patient's profile and then what is the plan today. The first case by Dr. Nagendra Prasad.
First case is Dr. Nagendra Prasad sir is going to start.
So voice is not clear.
Hello sir. No. It's fine. Hello.
Yeah, please go ahead.
Yeah. So this patient is a 53-year-old female, and she is having cataract in. We are going to operate left eye. She is having a astigmatism of minus 1.14 diopter at 133 degree. And K value is 45.98 at 114, and K2 is 46.10 at 24 degree. Our axial length is 22.93 mm, and we are going to implant clear autonomous lens of 21 diopter. Another eye is very well. So Dr. Nagendra Prasad sir is going to start this surgery. Everybody is seeing the microscope view, please. Is microscope view clear? Clear? Hello, Kunti sir.
But it's still not clear.
Hello.
Please focus. Please focus.
Hello.
It is well centered, but the picture is not that clear. Personally, the focus is not. Yeah, now the red glow is visible. It is little decentered, sir.
Okay.
Yeah.
Is it fine now?
Yeah, it's clear, very clear.
Okay, okay.
Nagendra sir, you will have to speak a little loud.
Okay.
I am utilizing horizontal chop with the vertical chopper, with the blunt chopper. You can have multiple pieces. And this handpiece is basically a new handpiece to me, and this is called active sentry handpiece. And this idea is to minimize the chamber fluctuation, and this is real-time feedback to the console and immediately compensate for the fluid loss into the AC. You can just see how efficiently and without any fluctuation I did my nucleus consume. I consume the nucleus. Visco, please. A little bit of visco. I am going to remove this is my preferred method. I have been using this bioluminescence since ages, so I will have better access to all the content of the capsule. It is centered?
Very well centered, sir. The capsular access is very well centered.
Very good, very good. Engage the fiber and pull it towards the center, don't consume. Here you have a little more space, so always bring towards the center, then aspirate completely. Gravity-based machine is also good, but you don't have control over the intraocular pressure. In this machine, this is definitely better, and it controls the intraocular pressure very well. So patient comfort level and difficult cases, like if you are going for like high myopia and all, so you have a preset level of intraocular pressure, and that is comfortable, and immediately you can always manipulate. This particular patient is very cooperative. It is not, but you can always do that, and I think you can always put on the Verion system, and yeah, it is a monofocal IOL.
Sir, this is questions that you started access, and before that you just injected Biswas. Any advantage, like normally what we are taught in Arvind, after you do access and when you start Phaco, then you just inject Biswas and just like the other self technique. Then after injecting Biswas, you inject Biswas. So you get that in the initial only.
Yeah, because in my mind, my opinion that if you inject this,
long back it was believed that if you inject Visco, the clarity will be not as good as the sodium hyaluronate, etc. And doing Rexis may be difficult. This was a concept I think long back, 15 years back. Now, I mean, many people do.
Only,
I do it 10 times under Visco, and there's no harm, there's no problem with clarity, there's no problem with moving the flap. As you will see.
only problem Dr. Rajesh is if you move the flap, which is very difficult to move the flap if you overfill it with the viscot and kind of thing. So nothing, otherwise I don't have any problem in using, and it goes towards the endothelium and it protects the endothelium. That is the basic idea. So far as the clarity is concerned, I don't find any difficulty in having clarity and doing Rexis due to visibility problem.
Sir, another question is, active fluidics is, as I presume, is from closed chamber. When you increase the side port, will that affect the active fluidics part?
So there is no. Actually, there is always a compensation system with the handpiece, and also pop up the extra fluid into the eye. So active fluid is not going to disturb. So I have not increased the size because we have not utilized the side port. Otherwise, main incision I am using, and because my instruments are 20 gauge and the side port is 21. So that's why I have to little bit of engagement is there. So it is not, it doesn't have any chamber stability and active.
And with this additional advantage of active sentry, the risk of surge or shallowing of chamber, mild, even if there is a little bit of leakage, that is compensated
this active senti handpiece I have used for the first time in this OT. So I have heard about it very well, and so far as the things I have heard is very stable chamber. I am getting a stable chamber with the active senti handpiece also. So this is definitely it is very difficult to compare right now because this is quite the first case. If you go for the difficult cases and all, then you will have a real difference. You can compare and tell about the activity. But as per the data and as per the technology is concerned, definitely this is a higher advancement over the previous handpiece we have been using in day-to-day practice. So, little those who have come.
How do you know about it?
That is very good lens, and material is so good that so far as implantation is concerned, so far as the clarity autonomous system, it is very comfortable and doesn't add your stress to how to load the lens, and whether you are loading, there may be chances of getting some difficulty like haptic capture, optic capture, and also we don't have any. Though it is not there in any of the setting which are of lenses, but even then to feel better with this autonomous system, which is very good system, delivery system.
Studies have shown that with the carry-on system, the rest of these
sudden jerky movement as well.
listening is
It is also clear to me.
Very minimal.
Glistening free, tissue free. The yag rate is, as per data suggested, is 1 or 2 in 2.5 in the episode groups, and here it is claimed to 1.5 per year. So this is very ratio friendly.
Dr. Rajesh, actually it is very difficult to exactly say that. That's what you meant was with the HPLC, if you are implanting the lens, then even if you stop, there can be some movement as well. But it's very difficult to say because there's hardly anyone who has tried that and seen that. So difficult to comment on that, but yes, people can have their own experiences by trying that.
I have implanted many lenses of Playland since its launch, and I have been, initially I used to inject Scott, but later on I just discontinued, and usually I inject HPMC into the cartridge and it goes well, very well. So my experience is very good with
It will definitely be very good. I think for a condition of IOL, I would not prefer using Biswas because removing Biswas is
difficult.
Very tedious. So I would rather use 1% sodium hyalurate for implantation of IOL, which can very easily be taken out and aspirated easily rather than using Biswas for implantation of IOL.
Rightly said, Dr. Rajesh.
Sir, any reason for not hydrating the main port? Your mouth was perfectly alright, that's why you have. But should we keep on hydrating the main port or should we stop?
I stopped using main port hydration. I only hydrated the side port. chamber stability and later on. And it is well tight. I keep the intrasurface slightly above on the table from the normal. So it keeps the lid closed with the intrasurface high on that side. And it is no need to push to hydrate the main incision and increasing the stomach hydration with the main incision. So so far as this is working well, so I continue it and I don't find any problem in using.
If there is question from Dr. Lasik on this.
Yeah.
Sir, my question is, your main code incision was 2.2.
Yeah.
When I am using this lens, in case of 2.8, usually I am using putting the iron under the BSS, each and every case.
Okay.
That case, I am facing the problem. The leakage of that, that's why the chamber goes flat. That's why in this case, I am again using viscoelastic in the chamber and putting the iron. Two cases I pressed the last in this case. Then I changed the visco to other company, and nowadays I am doing the BSS is 2.2. But this problem is the 2.8 incident.
Yeah, definitely. The 2.8 is will leak, but 2.8 doesn't leak. And in this particular case, I have tried once without BSS this clavicular lens. So it is difficult to control the movement of the lens and chamber collapse is there. So I discontinue that and I go as per the textbook or company.
Just for my curiosity, using the front, the chopper.
Yeah.
Just want to get cataract, or you can go for the even the 60 or better. If you are not using the hooking any part of the lens, just by using the front chopper in this case, I just
No, blood chopper is also good. You can go with that, but it is blood chopper, blood sensitivity also you can do with that grade of cataract. But in the blood chopper, what happens? There is a blunting of chopper. There is a edge of the chopper which cuts effectively and easily, and you can have very effective chop. So you can, if it is slightly thicker, so you have complete 180 degree chopping with a single chop.
Industry is always one step ahead. They also do this CCC under BSS. But let me go back to how many people are putting IUL under BSS. and all hydrophobic or hydrophilic, any.
Hello.
And what are the problems which we can face, and what are the precautions we should take while implanting hydrophobic under BSS? Because there are chances that the IUL may rotate a bit. Sometimes there occurs rotation of IUL or
Unfolding of oil into the
It just reduces your time.
Yeah.
And it reduces your use of viscoelastic. And if you are putting a toric lens, you are absolutely sure that everything is out. Even after using a 1% sodium carbonate, you can ensure that you have removed all the viscoelastic. But yes, it reduces your surgical time and it reduces the use of viscoelastic. That is one thing that I felt.
Only thing is
And also is taking implant, ICL is also under this cases. What I do, I use the irrigation mode of the biomanual from the side mode and then inject. So I've done that as well as, we are setting a manuscript comparing viscoelastic versus hydro. So it is doable. Only thing is that you need initial 1 or 2 cases, you just need to get adjusted and then after that.
only problem under BSS that if there is a certain jerky movement of the lens, though it happens in HPNC also, but there is a less protection than so you will directly hit the posterior capsular.
I wanted to say that it's very good technique, but before doing that, you ensure that your room size is good enough and your version of the multi-piece, the multi-piece under irrigation, because the tactics can sometimes hit the cornea very badly.
The biggest advantage under BSS is in the
Do you have anything to say about the irrigating, the direction of the fluid? Because many times when you inject the hydrophilics, preferably, they topple down also. So is there something you prefer to do that your direction of the irrigating fluid is away from your injecting IOL or something of that sort?
No,
downwards so that it doesn't come in the direction of the implantation of IOL. Otherwise, there will be jerky movement. So it should be directed downwards so that the IOL is, once it's there, the back, the direct flow is not pushing the IOL. That is what is the problem.
Only one can already improvise this direction of fluid. Like suppose if you have to implant a 45-degree IOL on a temporal side. So if you inject the temporal side, the opening should be 180 degree. So if you direct the fluid while in between it automatically pushes the lens towards the 90 degree. So you have a little, you have to rotate very less for the concentration of toric. I am talking about the toric eye. So you can advantage of that is also maybe there. Technical advantage, though I have been utilizing in many cases.
So rightly pointed out that DSS saves the time.
Yeah.
And the anterior chamber is very clear of any viscoelastic devices.
Even next information is very.
But we need to be very clear and cautious, as Dr.Subhash said, that it needs to be a slow process of injection so that you allow time to the lens to come to its original state. There is a memory time, lag time is there, and if you inject it before the memory time is achieved, then there are chances that the lens may topple out. So it needs to be a little bit slowed down. Thank you very much, Nagendra sir, for wonderful surgery.
Thank you.
Prasad.
Thank you everybody.
It is always a pleasure watching you from our senior residency days. So thank you again.
Thanks, Dr. Subhash, and I want people for big support for this workshop and all. Thanks. Thank you all for patience.
Thank you, Nagendra sir. Wonderful surgery.
Now I request Dr. Subhash to present a bouquet to Dr. Professor Rajesh Sinha, Professor of Cornea and Refractive Unit, Happy Center of Sciences, Professor of Ophthalmic Society, Secretary of ISCKRS, and a friend, son of soil. It's always a pleasure welcoming you, sir, this land. Giving you a talk on advancing with myopic correcting IOLs. That is another hot topic. Everyone is trying to learn the art of granting myopic IOL and what are the finer points which we should keep in mind. We are surely going to learn something from you.
Thank you, Dr. Vibhuti, and I would like to thank Dr. Subhash for having me here. And I'll be talking about understanding of multifocality and presbyopia correcting IOLs. So, the IOL implantation started way back in 1949 when Harold Ridley gave this concept. I mean, this concept was one of his students when he said that you haven't replaced something for the lens that you have removed. And from there, Harold Ridley started thinking, and then what he found out
Mr. Abhishek, can you, there's a talk going on.
Yes, sir. We are not audible. He is not audible here. Dr. Rajesh sir is not audible here. There is some problem.
What he found out, Harold Ridley found out that he was a surgeon of Royal Air Force. He found out that pieces of canopy that went into the eyes of the Air Force pilots, they remained sterile in the eye. And that's what he thought, that probably this material can be used for IOL. And since then, a lot of advancements have happened in terms of material of IOL, in terms of injector system of IOL. And the basic idea was to achieve 6x6 vision. That was the aim initially. But then what happened, once we achieved 6x6 vision, people started telling that still we need glasses, still we want to get rid of glasses. So how can we do it? And then came the concept of multifocality, because the eye itself, changes its shape to focus for distance as well as for near. And this is what it does. The shape of the eye changes in order to focus this image for near. But so this could not be replicated, till date has not been replicated, because we haven't got a liquid lens or something like that injected into the capsule after removing the cataract refractors material. So a lot of things have been done. People started initially by using monovision, like corrected one eye for distance, one for near. Then came the concept of using multifocal IOLs in both the eyes. And multifocal IOLs are basically designed on the principle of simultaneous vision. And what happens that there are two images that are formed by the same IOL. If one image is dull, if one image is not clear, the brain blurs that and ignores that and interprets the clearer image. And that is the concept of simultaneous vision, based on which so many IOLs have been tried. There have been multiple foci for distance, near, and this is how people started modifying the IOLs. And three concepts basically came. One was that you can have alternate rings of refractive power. Then came that, okay, you can have one power on the anterior surface, aspheric lens. Then you can have diffractive plates, which split the light for distance and for near. And the third concept that came with one of the lenses was soft optic-haptic junction, resulting in pseudo-accumulation, which again failed miserably because of some reasons. So the concept of multifocality came long back when, at that time, the first lens that was implanted was New View by Precision Cosmic, which finally, became Bausch & Lomb. And then multiple modifications have been done, and the first FDA-approved multifocal lens was this array multifocal lens. However, there were so many problems as far as photic phenomenon and even the distance and near correction and all those factors are there, which were not known at that time. Amongst the current generation lenses, we have this Technics lens, which has an anterior aspheric surface and diffractive posterior surface, and then the Restore multifocal lens Alcon, which has apodized diffractive surface on its back in the central 3.6 millimeter zone. And this basically, what it does, this apodization is gradual reduction of blending of diffractive step heights. Now why? We have been listening, we have been knowing about that, diffractive heights, diffractive plates are used for correction of, variable distance. What it does, it is basically a partial kind of a lens, which partially it splits the light into two. Partly it focuses for near, and partly the light goes for distance from the aspheric anterior surface. And this is what the diffractive steps they do. And part of the light causes some scattering, and that results in the photic phenomenon or the visual disturbances that we have in the multifocal lens. So this was the concept. And then, as I said, the soft haptic junction was utilized in this crystal lens, but what happened that with the fibrosis of the capsule after a couple of months, this became a monofocal lens, so it failed miserably and it's out of the market. And of course, all these multifocals had their problems, halos, glare, etc. And people kept on working on it, kept on thinking about how to reduce this, because there are a lot of patients who keep complaining for it. Then there's another complaint that, all these multifocal lenses that we have been talking about till now, what I was talking about, these are all bifocal lenses. They are either they work for distance and they work for near. They are actually not multifocal, they are bifocal lenses. And people who, these days, who use laptops, computer system a lot, they started feeling the heat that, even if with the multifocal or the bifocal lens, the intermediate distance, which is 60 centimeter, that was not getting focused. They were not able to use the laptop, they were having problems. And that gave the concept of, real multifocal lenses or multifocality, or having focal points at various distances, near, intermediate and distance. And that gave the concept of the extended range of vision, which we have been talking about. So the extended range of vision, the first approved IOL was the Technics of J&J, and it used the diffractive acrylates embedded on the optical surface of the lens. So once again, whenever you have these diffractive acrylates, as you can see here, it will again split the light, split it, elongate it, and that way it will increase the depth of focus. Then a couple of other companies came, our own Indian company, Appasamy also came with the suprafovin focus with this design, and this also has some pluses and some minuses. Now the current generation is the Vivity extended range of vision lens, which is from Alcon, no financial interest. This has a theoretically better concept. Normally what happens that either you have multiple zones wherein you refract the rays at multiple areas at multiple points for distance, intermediate or near, or you have these diffractive plates. Whatever you call it, some people call it apodization, some people call it Egglet design. I mean, these are all games of terminology that have been played, but these are all diffractive plates. And these diffractive plates, they split the light actually. And when they split the light, what happens? That some of the light is lost, it is scattered, and that creates the photic phenomenon. The problem of N6 and 6.6 is no more these days if you actually select the patient properly for a multifocal lens. The problem is more of the visual disturbances that we have. Now this Vivity lens has a unique design which is based on wavefront shaping of the IOL. And that doesn't split the lens. It actually stretches the focal length by its own, actually how the physics works, nobody knows except the R&D of the company. But what it does is that it elongates the focal length. And there is no diffractive plate, so that it doesn't split the light. So that is a plus in this case as far as Vivity is concerned. Then of course multiple trifocal lenses have come into practice, and they provide good vision for distance, for near, for intermediate. A couple of trifocals which are quite popularly used. One is 80 laser trifocal from Zeiss. It has a plate haptic, and many people have the problem with plate haptics. They don't prefer plate haptics for various reasons. The Panoptics lens is an open loop design which is from Alcon. This is again a trifocal lens. What it does, it has a enlightened optical technology. What it does is that, normally whenever you are having a multiple foci, you have a sequential diffractive, points. So it is divided in this form that if you have, normally what people felt that 80 centimeter is a bit far off, 60 centimeter is considered more for the intermediate. And with some of these trifocals, it was not coming for 60 centimeter. Now with this technology, what they have done is that they have kept one foci at 60, one at 40, and then they had to double for the 60. This is how physics works. So 120 centimeter was kept, which was stretched to distance. How it has been done, again the physics, nobody knows except the R&D, but this is what they claim, that it is stretched to the distance, and that is how at 60 centimeter, which is the desired distance for intermediate vision, you can have a good acuity. And it is a good proven lens actually, and we also have quite a decent experience, and it works very well. It is mostly it's a single piece aspheric hydrophobic trifocal IOL, 6mm optical zone, and it has three foci. One is at 40, one is at 60, and one is for distance. So some people say it's quadrifocal because the 120 thing has been stretched to distance. So whatever you call it, but practically speaking, it is a trifocal lens, and it utilizes light transmission maximally. Now the problem with visual disturbance is this, that if you don't utilize time, it depends on how much light is being utilized. Whatever is unutilized, that results in visual disturbances. So the maximum, even this lens is not absolutely free of visual disturbance. Patients have to learn to ignore, but it has minimized the visual disturbance because it has utilized the light maximally. So amongst all the available lenses, the maximum utilization is seen with the Panoptics lens. So even now, when science has advanced so much, I guess we need a bit more of advancement as far as presbyopia correcting IOL is concerned, and it's a tricky situation. It can be very satisfying for some patients. You all must be having this experience. Can be reversed for some. Proper case selection is the most important thing. And what I have felt and what most of the people have felt is that 6.6 and N6 is very much achievable with many of these lenses. What takes a lens to higher pedestal is that how much less is the visual disturbance, how much less is the photic phenomenon, how much maximum is the light utilization being used, and how minimum is the splitting of light that is being done. So that is something which people are working on, and a lot of these current generation lenses are quite good, and most of the patients are very much satisfied, and I guess maybe with time we may have something which is absolutely physiological. That is what we are praying for, that something liquid lens, if it comes, it increases and decreases the thickness of the lens as a normal crystalline lens. That is something which is ideal. But till date we haven't achieved that, so whatever lenses we have, these current generation lenses are providing good patient satisfaction. So thank you very much for your patience.
Thanks, sir. Very nice lecture. Sir, being an ophthalmic surgeon, cornea surgeon, what lens you would recommend for yourself? Type A personality.
With the current concept in mind, I may go for a Vivity lens, because with Vivity, distance and intermediate is probably not an issue, although I don't have that much of experience of Vivity, but the theoretical advantage of Vivity is there. So I would like to have a little bit more of experience. If I don't take the name of any company, Vivity lens or anything, then I would say extended range of vision lenses. ERV lenses I will prefer, because I don't want any visual disturbance. That is one. Number two, I would like to investigate myself, because angle alpha should be less than 0.4 or 0.3. That is what I will keep for myself. Although for less than 0.5 is also okay. So that will help me in having less of photic phenomenon, even if I undergo a trifocal implant. Because there are some ophthalmologists who have undergone, one of our teachers has undergone trifocal implant, and he had discussed before that, before his surgery also, and there are many patients who are doing very well with trifocals. So, but slight, I would be a little biased toward the extended range of vision lenses in the current scenario, because for absolute near, I don't have any problem in using glasses. I will use, but I won't have any photic phenomenon. I will have a good intermediate and distance vision. So that is what I would prefer.
Sir, kindly increase this photic phenomena by creating more steps on the edge slope of that plate.
So that is what is being done, and that is
the focal range.
Absolutely. So the step should be so minimal. The gradient should be so minimal that instead of having multiple foci, it will create a continuous. But it doesn't. To tell you frankly, it doesn't. Every diffractive step splits the light, and part of it is split for near. So that is there. Till date, I guess, they have minimized the step. That is the method of, all these upgradation and all these non-upgradation, whatever they have done. They have done it, but any diffractive step is there, it does cause some splitting of lens. And that is why I told, because there is an equivalent design with the symphony lens, I will not use, no financial interest, but I will not use symphony lens. I will either use the Alcon Vivity, or maybe, who knows, I had a good experience with even Upper Suprapo.
We can blunt that peak of that step so that we can reduce the photic and
I completely agree with you. Actually, that is what is desired. But But till date, even if we have reduced the step, there is some splitting and there is some loss of light. That is there. So, I mean, maybe what you are telling, maybe it happens in future. Who knows?
Another idea, can we keep this technology in microscope lenses so that we can get a better focal length? This steppings and all. Microscope, that operating microscope, we can change the value of it.
He's talking about yes.
Dr. Rajesh, can I put my views on this?
Hello, you are able to Nandi?
Yeah, Dr. Nanda here. I would like to put in my views on the topic Dr. Rajesh covered. Well, there are two things we are talking about. One is called floating phenomenon, the other is called contrast loss.
Yeah.
So when you have scatter more than 10 to 12% of your light, there is a loss of contrast.
Yeah.
And when you have diffraction at different points, so there is halo and photic phenomenon.
Yeah.
Now the diffraction is being reduced because the steps are being more gentle. So this is the principle of most of the newer lenses where the steps, which are quite significantly visible in the older generation multifocal lenses, are now not clearly visible because the steps are now gentle. They are made, not sharp, as some doctor said. So if you want to put in a multifocal lens in your both eyes, there are two things I would consider. The first is you must know what is your spherical aberrations and your other aberrations, thyroidal aberrations, and segregate your corneal from internal aberrations. If you have significantly high corneal aberration, no multifocals. Obviously that is not indicated. But if your reticular aberration is high and cornea is good, you can go in for a trifocal or a VVT, whatever you say. And personally I think if I do not drive myself, so I will be happy with a trifocal, panoptics rather than VVT.
Okay. So, obviously these things, as far as the evaluation is concerned, that evaluation has to be done. That if there's corneal aberration, no more multifocal. If there is internal aberration, obviously you can go ahead. So these things definitely have to be done. And the steps, as you said, in current generation lenses have been reduced, but still the steps are there. So that is something which is very much there. But yes, if otherwise if the eye is fit for a multifocal, you can go ahead for a trifocal as well. And this is something which can be done. Provided, obviously for myself, I would like to get all the evaluation done first. Eye trace, ocular surface, everything. For any patient actually we do it. For any patient we do. So for myself as well.
No, but what he said is that, okay, fine, all the aberrations should be recovered. But before going to multifocality, is it essential to go for
Is there any other question?
Yes, for multifocality it is very essential to know the aberration, and particularly that way, if you can do it, that is better, because in some patients you have more corneal aberrations and some patients you have more internal aberrations when you talk about the total aberration, and that can be done by eye trace, but it's not available everywhere. So I don't know, but yes, if it's done, that is ideal.
So last question from Dr. Nagendra.
Yeah.
Then we'll go ahead with the surgery.
Your take or any experience about having these lenses in pediatric cataracts and your take on that?
I will not use any multifocal lens in pediatric cataract because for multifocal lenses to have very good result, there are two factors why I said I won't use it in pediatric. One is that definitely the contrast reduces because of whatever light is lost and all that. So that I would not want in a child. Most importantly, for a multifocal lens to have a very good success, the myometry should be absolutely right on. But in children, what happens that the axial length can change with time. Even after say 6 years, 8 years, 10 years, sometimes there is some change. And any sort of change that can happen after implantation of IOL, I would not want that. So I will not use multifocal lenses
thank you Rajesh for your talk, and later on we are going to learn a little bit from you during the surgical session also.
So this is the last question. Since surgeon has already watched and is waiting for surgery, so we'll rather move to the live surgical session and then later on we can take it. Thank you very much, sir. And thank you, panelists for this first session. I invite panelists of this session, Dr. Rani, please come on the stage. And Dr. Ajit Subhash. Next panelists, Dr. Sudhir Kumar and Dr. Pranav will join a little later. There is slight change in the schedule. We'll move with the live surgical session, and Dr. Ashok Nanda is going to do the live surgery. For us, that is live surgery, trifocal toric with image guided system. So wonderful surgeries, surgical phase we are going to have. Dr. Nanda is a medical director and cataract of cataract and refractive surgeon, Contoura Vision Eye Hospital, Bhubaneswar. Also a teaching faculty as professor at High-Tech Medical College, Bhubaneswar. He has received gold medal in ophthalmology and ENT final MBBS and after PG, deep fellowship in comprehensive ophthalmology, LPPI Hyderabad. Numerous original articles in index journals in his credit, and also he is a guest speaker at various state journal and national conferences. Welcome, Dr. Nanda, for your live surgery. May I request Dr. Abhishek to please go ahead with the to elaborate upon the patient which is going to operate and the data sets which we have.
So the patient is 56-year-old male patient, and left eye is going to be operated, and plan is to implant monoptic stent 2.82, double X92 and so plan is to effective astigmatism is 1.66 diopter and 2D. So
I must give a big welcome to Dr. Pranav Ranjan, who came from Boring Road. I landed from Calcutta much before him. Thank you, Pranav, for coming all the way. And what you missed is a master at work. Okay? In place, and the lens is well aligned. So though you would really notice that the long axis of the posterior capsular ring was nearly aligned to the, I think it's a 180 degrees or close to that. So the toricity. But yet because Ashok could get the haptic in the bag and he rotated in the bag to the alignment of the toricity. So that's how we have a very stable anterior chamber. He's taking off the viscoelastic, which is coming out very well. And I think it was a great surgery. Remarkable surgery, and especially when it comes to a live surgery, then it becomes even more, even more amazing how he has tackled it so well.
Okay, there are some strands now coming. I don't know what it is coming now.
Even with the 30 millimeters of IOP, which he had set for himself, I think it was a very stable anterior chamber. The active fluidics and all the assessment of the anterior chamber depth. Are you using an active sentry also, Ashok? Did you use the active
Yes,
sentry?
I did.
Okay. So it's an irrigation controlled assessment of the anterior chamber, which again was giving a very good stability. I think the last time it just came up and a fragment. For our colleagues or junior colleagues maybe, the last fragment always should be taken up with a viscoelastic, and the viscoelastic cover of the posterior capsule is always a very good cover, so that the tamponading effect of the posterior capsule is there with the viscoelastic for the last fragment.
Actually, this patient had a component of posterior polar also. There is a PSC, significant PSC, and the capsules are probably thin and little more, you can say, floppy, which I probably missed because I was concentrating more on the leathery part of the cataract, not seeing the posterior capsule properly when I was doing. So my mistake was probably my focus was on the leathery cataract, not on the capsule. So during the last piece delivery, the floppy posterior capsule must have come up. And IOP being low, that probably could have not maintained the antechamber as deep as it should have.
One thing I have learned from Dr. Subhash, what he does, and I am doing it almost regularly, is that during taking out the last piece, I put a lens spatula in between the capsule and the paper, so that the last piece is in between the iris spatula and the paper. So that gives a lot of confidence that the posterior capsule is going to remain intact.
Yeah,
So that is one thing I have learned from Dr. Subhash, because he was doing surgery. I just asked him why you have put the iris spatula just behind it. This is one thing. Any fluctuation also that can take care of. So that is one thing that one can take care of.
एक चीज तो है और सर के पास केस गर्मी में जो आदमी दो कहने का मतलब है सर आज या कल सब
Ashok Nanda sir, please give for wonderful surgery, wonderful demonstration of management of complication, and that too live. We saw two masterly act right now. One was yours, how you did your PCR management, and the second was Partha's management of crowd. How we manage the complication among the crowd, how we need to manage that. So both the acts were wonderful to listen and learn from that. So there is one question. Once PCR occurs, then what are the planned options do we have, and how do we proceed? We saw you injecting Viscot to plug the PCR and then doing the management. At the end of the surgery, you were doing the aspiration also of the viscoelastic devices, as this was a toric IOL. There was slight disintegration of IOL also was there. So what are the finer points which we should keep in mind while managing these kind of PCRs?
The question is to me?
Yes.
Yes, sir.
Alright, so basically, first of all, whenever there is a rent, you have to first assess what is the extent of it, as Dr.Partha said. If you can see the edge of the rent, then it is okay to go ahead and not alter your surgical plan. Since I could see the edge of the rent, I decided to plug it and put the lens. My mistake was probably, as Dr. Prasad said, I should have given a transdermal to see any strands are left. Now, I did a vitrectomy and I presume that all strands are not there, gone from the antechamber. I wanted to aspirate out some more viscoelastics from all the sides. There, a strand, I got the strand at about 8 o'clock or 9 o'clock, and that's the reason why the haptic got pulled. So again, I had to cut that strand and replace the haptic in its place. The decentration, before I closed, you must have seen I tapped the lens.
IOL implantation.
what are the finer points one should keep in mind while doing the toric surgery? What are the minimal criteria on which you do toric implantation? And then how do you plan your surgery? And what are the finer points which you try to perform during the surgery to achieve the maximal outcome?
Toric actually has a lot of surprises. Many times when you do a toric planning, we look into the post-operative residual spherical equivalent. So that is not true. We need to actually segregate what is the residual cylinder from residual spherical power. So only then your toric plan can be proper. That is why variant is important, because it plans in such a way that you get to know what is the residual sphere and residual cylinder, not the spherical equivalent. So that is one. Second, it also takes into account the posterior corneal curvature based on whether it is a with the root or against the root. The K value changes accordingly. And these are two operative assessment. Intraoperatively, you should make sure, see the toricity, if it is, the lens is rotating in clockwise or anti-clockwise, it is still forgivable because it will not cause some amount of cylindrical power correction. But if the lens is decentering, it is less forgivable because that will cause more of, visual symptoms. The ghosting and the higher order aberrations will increase if there is a decentration. So you should try not to have a decentered lens when you are using a toric or a multifocal lens.
Thank you, sir. Sir, anything you want to add, sir? Partha, sir?
The stability of a toric lens is very important. So there are reports where they have in a PCR anterior capture, means the lens is in the back and it is reverse captured into the anterior chamber with the haptics inside the bag and the optic reversely above the anterior capsule. These are techniques that have been used, but it does not mean that in every case one can use it. Ashok's lens was more or less centered and more or less the toricity was maintained. Here again I would like to stress on a very important point. It is the stability of the wound, the stability of the anterior chamber. If at all a little bit of compromise of the toricity has to be done, it needs to be done. More of manipulation than required is not necessary. We cannot be spot on in such situations. Therefore, counseling the patient and the family is important at this stage, that the outcome might not be totally optimal, but maybe a little suboptimal. But in the best of hands, with the best of techniques done, I think it was a splendid surgery.
Any questions from the panelists? Yeah. Before that, sir, Dr. Nanda sir, one of the senior most ophthalmologists of Bihar, Dr. Professor ASP Sinha sir is here to bless you.
Thank you, thank you.
Sorry, Dr. Nanda, I have not met you earlier. It is such a versatile surgeon like Partha. I wish you all the best.
Thank you, sir.
In person very soon. Thank you.
Thank you.
Yeah, please go on, sir.
No, it's a well done and absolutely well managed surgery. I was able to see one of your live surgeries in the ARS just a month back. I saw 4 of his surgery and he's an immaculate surgeon. So very well managed complication, and we really have learned a lot from it.
Actually, इतना अच्छा सर्जरी देखने के बाद आप लोग को लग रहा होगा कि इस तरह के कॉम्प्लिकेशंस मैनेज करना आसान है, लेकिन सच पूछा जाए तो स्टेबिलिटी की बातचीत सबसे ज़्यादा स्टेबिलिटी था सर का मेंटल स्टेटस। इन्होंने एक वॉर लाइक सिचुएशन में हर समय अपना कूलनेस बनाए रखा और उस पॉइंट को जो करना चाहिए वो करते चले गए, और इसीलिए इतना अच्छा कर पाए, और यही एक एक्सपीरियंस सर्जन का फीचर्स है। यही मैं ऐड कर। थैंक यू।
Any other questions from the audience? We are waiting for our chief guest to arrive. He'll be here in 5 to 6 minutes now. So after that we'll have an inaugural session, and then we'll...
Can I ask a question from Dr. Partha and
please.
Dr. Nanda? I mean, how much of a difference is there between a varion and a manually marked for toric implantation? I mean, because everybody cannot afford to have a varion or a telescope. So, I mean, there are various studies which show that the final outcome, visual outcome, is almost comparable if the manual marking is well done and if it is put in the right place. So what do you say about that?
Absolutely. Absolutely, these questions we all the time keep answering. Is Varion the only answer, or Callisto the only answer to a toric IOL? It is really not. Because over so many years, all of us have done toric IOLs without very different results than what Varion is giving. But having said this, let us also remember the science of it. So when you put a mark, the pen mark on the sclera, usually the pen mark is more than 7 to 10 degrees. So there is an inherent error already of 7 to 10 degrees because of the marking. So the error is there, but the outcomes may be good. However, the outcomes will always change with the larger torics. If it is a toric more than 2.5, 3, 4, even an error of 5 degrees is going to give bad outcomes. Whereas if it is just 1.25 or 1.75, the outcomes will be good. But that doesn't mean that if we have an access to a better technology, we should not take up the better technology. The better technology is always for accuracy, and when we are promising accuracy because of the toricity, correcting the cylinder, giving that accurate outcome, we need to be as accurate as possible. So whether it's a slit lamp marking or a bubble marker marking will have its deficits if one can afford, and that is because of the patient's science to it. We should go in for the toric marking, either by the image related marking, which is the toric marking with the Varion.
Absolutely agree, Dr. Partha.
हमारे माननीय उप मुख्यमंत्री श्री डॉक्टर प्रसाद जी आ गए हैं हमारे बीच में, तो अब हम इनॉग्रल कार्यक्रम की तरफ चलेंगे. मैं रिक्वेस्ट पैनलिस्ट टू प्लीज टेक द सीट.
We were not taught by people of any different caliber than the teachers of the rest of the world. It has been our duty to take these teachings not only to heart, but to different places in India and abroad. And we do know that everybody who is there abroad or in different parts of India have made a mark of themselves. We do realize that roots are Bihar, and that's where we have been fed, nurtured and groomed. So whatever we do in any other part, be it in All India Institute of Medical Sciences, Dr. Rajesh Sinha, or myself in Kolkata, our roots are very much here, and this is where we belong to, and always grateful to this land which has given us so much to go on for life. The second thing is, today's Bihar is absolutely at the cutting edge of technology at least in ophthalmology, anywhere in the world. So the use of these phenomenal machines, expensive machines in Bihar is at par with anywhere else in the world. And as per the expertise of the surgeons is unmatched. Why? Because we do so many huge numbers that our skills are better than any of the surgeons of the Western world when they do just a minuscule of what we usually do. These are absolute truths, and you would see for any live surgery, whether it be the cataract coach by Ajay Devgan or Bob Osher, the surgical skills displayed is nowhere a match. So I think we have every reason to be extremely proud of our own Bihar, and salam to this land of Bihar. So now I come to the talk in which again it is the cutting edge technology which is done in the laser treatment of refractive errors. And the laser treatment of refractive errors have taken us to the stage where the accuracy, where the fundamentals of the science of the cornea is being incorporated in the laser technology of today. So the emergence of the topo-guided system, we all know that Lasik gives phenomenal results. At one point of time when we started Lasik way back 20 years ago, we did huge numbers, and when we ventured also to a number of dioptric error of nearly 12, 13, 14, 15. Next day, we had very good vision. A patient with -13 would come back and say, oh wow, what phenomenal vision I have. But the same patient, when he comes back a month or 2 months later, comes back with problems. Why the problems? We now understand. He would be reading 6/6 on the Snellen's chart, but would come back with night driving difficulties, with problems. And I have a patient whom I had done this -13 diopters of correction, a good residual bed left behind, patient reading 6/9, that was his best corrected vision in the Snellen's, but met with an accident 3 months later while he was driving a bike. Why? Because of the nighttime glare, the problems of contrast, and the difficulty of not having an aspheric cornea left over. And that has been a learning for all of us, and now we have been much more conservative. We do not do LASIK correction over 8 diopters most of the time, and ICL is there, and other modalities of treatments are there. But even with the wow factor of today, things are going to improve to tomorrow. And the Contoura Vision comes in with a technology that incorporates this amount of the topographic analysis, and why it is important for the topographic analysis to be incorporated into the protocol of the laser vision correction. And the higher order aberrations which we have been speaking about is what is determined also on the corneal topography. It provides an alternative to the correction of the higher order aberrations. We correct the sphere and the cylinder and we get a wow effect. But if it has to be standardized, if it has to be meticulously treated, the topographic analysis is important. So what is this Contoura Vision? A lot of noise again is being made of Contoura Vision. Really, does it help our patients? Is it worth the cost? Is it worth the expertise? Is it an upgrade, or is it something just that is going to pass away? Well, it is an FDA approved technology, and that's a very important aspect. And it is a topo-guided laser platform, and the eyes that are available today surpasses the current standards of the LASIK in terms of the patient outcome. So the future of LASIK surgery is actually the improved quality of vision. So we come back from a lot many years and try and improve the quality of vision, which has been improved by the laser vision correction with the Contoura. So how is this Contoura performed and what especially we do for this Contoura Vision? We all know that we have to do analysis of the corneal topography before we do a LASIK correction. That we have been doing for so many years. But now comes in this topolizer vario, which gives the assessment of the cornea. And the corneal assessment is important and it is incorporated into the systematic analysis of the laser platform. So when we do the wavefront guided ablations and we use the whole of the wavefront, the whole eye optics for the ablation profile. Now, the lower order aberrations and the reduced higher order errors are to be treated, but what we have is the limitation of treating the peripheral corneal aberrations. And these peripheral corneal aberrations actually give rise to the improvement of which would give rise to the wow effect and a betterment. Now, for implications, if there are higher order aberrations, there are numbers. And these numbers are also important. Do we need to correct every higher order aberration? Not at all. But if the higher order aberration is greater than 0.3 micron, then we need to correct it. And here is when the topo guided or the topography guided ablation comes in. Again, if you ask in a number of 10, does everybody need the Contoura? Not at all. But people who need the Contoura would benefit from the Contoura, and that is where this topolizer vario comes in. So we use the data from the topolizer vario, and this is the topography guided ablation, and the reliability of the measurement of this highly aberrated topographies that the wavefront sensors do not measure is given. So what we need to do, and that is the goal, is to normalize the corneal surface. And how we have been working on this wavefront optimized platform with the EX500 for very long. I was entirely happy of the 10 years of this wavefront guided, the wavefront optimized analysis that was given by the EX500. Very good results, patients very, very happy. But once in a while, a patient would say that, अच्छा तो दिख रहा है, लेकिन वैसा तो अच्छा नहीं, शाम के समय में थोड़ी दिक्कत होती है. So these are the patients whom we need to address the higher order aberrations. And when we analyze these patients, these partially unhappy patients or the unhappy patients, that's when the higher order aberrations came into play. So the wavefront optimized ablation profile is very good, but if the assessment of the corneal surface has a higher order aberration profile which is more than this 0.3, then it has to be addressed by the Contoura Vision. And therefore the visual acuity is better, the post-op symptoms are minimized, and the satisfaction rate is much better. So now, what are the advantages of this Contoura Vision? And 70% of the refractive errors are from the cornea. The wavefront guided technique considers the whole of the higher order aberrations, but the treatment is on the corneal plane. And the accuracy by which this topolizer determines the higher order aberrations plus the corneal profile of the topography is very, very important. And here what we need is there has to be a dedicated optometrist to be a valuable part of our team to assess this corneal topography. Because anybody in his whole practice, Subhash Prasad, with his huge number of patients, huge number of surgery, will never be able to do a proper analysis. It takes time and effort to do it. So a team member who is dedicated to the analyzing of this topolizer vario is important. Because the images are captured, some images have to be thrown off. Only 4 have to be retained, and those 4 should give a proper idea of what the Contoura Vision is going to give. The Contoura Vision is not dependent on the pupil size, and it is reproducible, and it is unaffected by the lenticular opacities or the vitreous opacities. And the peripheral irregularities of the cornea are measured very well. The potential advantages and disadvantages, if we look at the advantages, the highly irregular corneas that are beyond the limits of wavefront measuring devices can be taken up. the obesities with patients with media obesities, the natural shape of the cornea is maintained and it captures the data using the photopic pupil, which is again very important. Now, even with this, there are disadvantages and the rest of the media is actually ignored. So there is a chance of some underlying HOAs which may be there in the rest of the medias, and sometimes refractive surprises can happen. So this is the wavefront versus the topography guided custom ablation. And again, to achieve a successful outcome with the Contoura Vision, it is important that every step of the topographic measurements should be based, and inaccurate and reliable data from the topography has to be discarded. So the FDA results have shown that there is a decrease of the light sensitivity with the use of the Contoura. There is a decrease of complaints of the glare failure, especially in the evenings. Reading difficulties are better. Now, when is it recommended that the wavefront optimized ablation for the patient is required? Now, if there is a difference of, these are again very important numbers which have been an assessment over the years because of number of studies that have been done. So if the difference is greater than 1.25 between the refraction cylinder and the measured cylinder. Now, let us be important on the fact that whatever the subjective refraction is and whatever the topolizer's refraction is, there can be a difference. There is usually a difference. And that difference, if it is greater than 1.25, then it is important to note that. So if there is a refraction axis difference of greater than 5 degrees of the cylinder and it is a refraction of greater than 2, then this can be taken in. Whereas also if it is the difference of a greater than 10 degrees of refraction axis to the measured axis, the refraction cylinder has to be less than 2 diopters. So these are again calculations that have to go in and we have to place in the same way. So let's look at one patient first.
Just go back to the last slide.
Yeah. This one. This one?
Yes.
Yeah. So if a patient has a total sphere and there are no higher order aberrations, the cylinder is also minimal, this patient might not be a patient for the customization by the topolizer radio and might not need a Contoura. Now, here again, when is it recommended that the wavefront optimized ablation to a patient will have to be, and these are the conditions. So difference of greater than 1.25 between the refraction cylinder and the measured cylinder. So that is one criteria. So measured cylinder is what your subjective refraction is, and the refraction cylinder is what the topolizer gives. Now, the axis is again important, and the axis, the difference of 5 degrees between the refraction axis and the measured axis, the cylinder has to be greater than, can be greater than 2 diopters. But if there is a difference of greater than 10 degrees between the refraction and the measured axis, the refraction cylinder must be less than 2 diopters. So these are important criteria on which the Contoura Vision works. Let us look at this quick patient. We have a series of patients, but I'll just take one eye of this particular patient. And here, what we had is a refraction of -10 diopters, -1 diopter of SIL, and the topographic astigmatism was 1.93. So there was a difference, and there's always a difference. So here we have, as you can see, that 45.5 diopters there, 47.1. Okay. Now, when we did the topography, there was this amount of 1.93. Now, when we looked at the Zernike polynomials, and you can see there that there is quite a lot of higher order aberrations of trefoil, coma, and some amount of spherical aberrations as astigmatism as well. So the HOA is more than what is required to be there, and if this patient can be done with the topography assisted Contoura, then the patient would benefit. So the step 1 of the planning is very important. So we take many images and select the best 4 topography images, and of these 4, the machine calculates the one of an average. After that is done, then the patient's data is placed in, and our patient's data was -10 with a -1 diopter of cylinder. And then the higher order aberrations are placed in, and the higher order aberrations would give an ablation of approximately 6 microns. So that is again acceptable in such a patient. We do not want a very, very large ablation just because we have to correct higher order aberrations. Then selecting the axis of the cylinder to treat. So remember, there was a variation. What our subjective refraction was -1. You can do that. -1 is there, and the calculated one from the topography was 1.93. So there is a difference. So how do we go ahead with this difference? So then what we do is we select the cylinder to be treated, and this is again important. So we select something in between -1 to -1.93, and we select 1.47 for this. So once we select 1.47, which is a little more than our subjective and a little less than what the topalizer has calculated, we need to make some adjustment also for the spherical equivalent. So we have to adjust the spherical equivalent, and thereby with an adjustment of the spherical equivalent, we come down from -10 of correction to 9.75, 0.25 we take off. So we have a treatment plan of 9.75 with a -1.47. Our subjective refraction was -10 with -1. The topography has deviated us from the subjective refraction to this calculation. And the final nomogram with the EX500 gives us is again a little less than what we need to do, and that is a methodology which the company gives us, and we come down from 9 to 8.75. So the final treatment plan from -10 with -1 cylinder, what we would have used with the wavefront optimized, has now come down to 8.75 to 1.47 of the cylinder. And the patient gets this good result of 6.6, which was her best corrected, and the patient gets back very good vision with an assessment of the pre-post-operative results. I think we have got a lot of data, but I don't think we'll go through it. I think Rajesh would be waiting for surgery, and if we have time later, we can always discuss all this. And the best part is the beauty of this wavefront optimized is very much there, but Contoura is an upgrade of it, and the Contoura should definitely be taken up. And if someone is using the wavefront optimized, the next jump is to the Contoura. It's an add-on. It will give very good results to those select group of patients who require the Contoura. Thank you very much for your patience.
Thank you, Dr. Partha, for giving us an insight on Contoura Vision. Although it's not easy to understand this Contoura Vision, but you have made a great effort, even for people who do not understand this, to differentiate between a Contoura Vision and a topographic analysis.
Sir, it was a very nice presentation on a very complicated topic, I would say. But the problem is now I think I'll have to refer most of the patients who come up for Lasik to Subhash sir, because the criteria that you have the criteria that you have mentioned, most of the patients fall in those categories. So nice presentation, sir.
OT is ready for live surgery, Dr. Abhishek?
Yes, sir, OT is ready, and Dr. Sinha sir is ready to operate.
Okay. So we end with this session. Thank you very much, all the panelists. Please take your seat. And may I request Dr. Nilesh Mohan to take over from here now.
So thank you, Murthy. Coming session, I would now invite the panelists, Dr. S.K. Pandey, Dr. Shivendra Sahai, Dr. Ashish Shekhar, and Dr. Ritika Sharma to come up on the dais. So there has been some shift in the total program, so now we'll be continuing with the live surgery. So Rajesh, are you ready with your surgery?
So just I am going through the patient profile.
Yeah.
So it is a 58-year-old female and right eye has to be operated. Her axial length is 22.87 millimeter. Keratometric valence K1 is 44.50 at 190 degree. K2 value is 44.79 at 29 degree. And plan is to implant Panoptics for 23 diopters. So it's a trifocal Panoptics lens getting to be implanted in this surgery. So what do you advise?
I think we had a talk earlier of Dr. Rajesh Sinha regarding the tools. So now we'll be seeing his surgery, and whatever queries you have in your mind, we can interact with him. Rajesh, over to you.
Yeah, just in the transitional area, one may require bimanual, but without support of anything. So, normally, many times I don't use it, and so you can do it without, and you can do it with as well if you want to have a guide that, okay, you're not going too far, in the periphery, or you're not being very small. So, I mean, it's the personal choice that you can take a guide as far as the size of capsular axis is concerned. Otherwise, with experience, it may not be required.
The advantage of variant systems in such type of only trifocal cases can be as lenses than that. Side effect in cases of minimal estimation 0.5, this image guided system can guide you. Moreover, at the end you must have seen the centration. In the end, just
Dr. Sundar, you have to be a little louder. I cannot hear your question.
Whether you can know whether your lens is properly centered or not. So these are the other advantages of Vision system in only trifocal cases. But of course, in trifocal toric or only toric, other advantages of pre-operative measurements and good.
Absolutely.
So here's Dr. Ritika.
Yeah. So nice to see you after so many years.
Yeah.
So just my question is, what is your rating for the present available trifocals? How do you choose or how do you select the patients and how do you rate them?
Patient for?
Trifocal.
Trifocal options. See, trifocal again, as we were discussing, that anything in the media, like you start from the tear film to retina, if there is any abnormality, I don't prefer any multifocal, trifocal, bifocal, or anything, because that will have a very bad impact on the quality of vision. But if the media is fine, like cornea is good, the tear film is fine, that can obviously be monitored and you can improve it if it's not that great, so that is manageable. And retina is fine. Cylinder is obviously less, but if cylinder is there also, like 1.5, 2.5, whatever, then you can use these Panoptics toric. If it's a very high cylinder, in that case you have to rule out other reason of contact clarity. If you have eye trace available with you, then that is a good tool to give you the idea of angle alpha and the separation of the aberrations between corneal aberrations and internal aberrations. You have a total aberrations of some amount. If majority is by internal aberration, this means that that is from the lens. So if you remove the lens, put an IOL, any IOL, multifocal IOL, you will have good results. So corneal aberration should be less, should be minimal in order to implant the trifocal IOL. Second thing is that angle alpha should be less than 0.5 in these trifocals, wherein you have a central ring and then refractive plane. So you don't want your primary rays to focus to the refractive plane. So that is the basic idea. So the angle alpha should be less than 0.5.
There's a large debate regarding the early glaucoma patients. Few studies have come which have shown that trifocals, earlier we used to exclude everything, like patients of glaucoma, diabetic retinopathy, before any lasers and all, from this group. Now some studies have come which say that early glaucoma patients can undergo trifocals. So your take?
See, glaucoma patients can undergo trifocal, there is no problem in that. It shouldn't be, the field effect shouldn't be too much that, it can create problems, that is one. If it's an early glaucoma and, even mid glaucoma you can manage. As far as diabetic patient is concerned, my chromogram is that if there is a diabetic, now there are two things, whether he has any diabetic retinopathy or not and what is the age of the patient. Now suppose there is one diabetic who for say 5 years, his age is 50 years, I will not put a trifocal in that because maybe at the age of 60, 65 he may have significant diabetic retinopathy. Second thing that I would like to see is that what is the glycemic control. Now somebody who is 65 years old, diabetic, no retinopathy, good glycemic control, I will go for trifocal. I was just discussing with Ashish about one of the patients and told that there is a patient 65 years old, good glycemic control, no diabetic retinopathy. You don't expect, if there is a good glycemic control, you hope that the patient will continue to have good glycemic control in the near future as well. And the next 10-15 years at least, he will not be having any significant retinopathy. So, good 15 years of good quality of life by having good distance, intermediate and near vision, that is enough. And maybe later on also, he may continue to have a good glycemic control or may not have a significant diabetic retinopathy. The idea is not to just, the microaneurysms are not going to cause any problem. Any maculopathy is going to cause problem.
Dr. Rajesh, I generally use for trifocal only on these cases which are CWC reading or kappa reading is below 0.6 and it is easily available in the IM after 700. So in those cases which we just
Sir, can you just repeat once again what did you say?
Hello?
Yeah.
I usually go for trifocal only in those cases which are CWC reading is 0.6 or below, and in those cases which are media is totally clear and there is no complications. Glaucoma is not any contraindication, but generally diabetes, as you say just earlier, it is a good contraindication where you should not use for that. And obviously other complications like disease should not be available. But what is most important is CWC reading. Otherwise, you will land in the problem after the operation.
Most important
is it any other specific criteria for choice of trifocal lenses?
What's the last one did you say? Most important is?
CWC, that is Chadwick called reading. It is also called.
That is fine. Yeah. So that's what I said, that, instead of angle kappa is more significant for refractive procedure. It is angle alpha, which is the angle between the visual axis and the center of the limbus. Because your lens centers at the center of the limbus. Because at the center of the capsular bag and at the center of the limbus. Now the angle between that and the visual axis, that should not be more than 0.5. So angle alpha, that is important for IOS. And of course, as you said that the other things are contraindications. Yes, I agree with you that glaucoma is not a contraindication. The only thing is that if it's an advanced glaucoma, then it becomes a problem. So if it's a very advanced field effect, etc. In such a case, it's always better to put monofocal lens. But in the mild glaucoma, you can go ahead. Diabetic retinopathy, if it is there, then I will not put multifocal or any trifocal lens.
So one quick last question.
Yeah.
Sir, Dr. Rajesh Vivity here, sir. So it's such a beautiful demonstration of the surgery, very methodical for us. And sir, one thing I want to ask that what is your experience with the regression in trifocal cases, especially the how much initially it was 6 and 6 and how older or how much you got that decreased vision or lateral?
Well, actually, what happens is that, what we have noted is that these lenses, the effective lens position does not come on day one. And what happens that the lens settles down and the gap between the capsule and the lens reduces with time. Now, if the patient, sometimes what happens is the patient may not have an absolutely 6/6 on day one, but on day 3, 4, or 1 week later, he will develop 6/6 vision. Or somebody has a 6/6 on day one, maybe after a couple of weeks or 2 weeks, he will have 6/6 partial. I mean, these things are possible because of slight backward shift of the IOL and the effective lens position. That is one. As far as regression is concerned, I guess we will have to, we do have some cases wherein there was some change in the refractive status, but regression terminology, I don't know whether we can use in this or not. And the second thing is that maybe we need to follow up these patients for 5 years or so. Then we will be in a better position to tell. That is one. But yes, one or two cases we do get changes from day one to say a couple of or a few weeks for a couple of months later.
So thank you, Dr. Rajesh, for an excellent demonstration of the surgery as well as giving them and solving the queries and the nitty-gritty of the procedure and whatever queries the participants had over here.
Thank you.
Thank you, Rajesh. Thank you so much.
Thank you.
So before the 14 is being prepared for the next surgery, I would invite Dr. Ashok, Nanda, whose beautiful surgery you have seen in the earlier session. There were questions coming up about the necessity of the image guiding system and all those things. He will have a wonderful talk and you will interact with him on the topic of image guided system. When, where, how mandatory is it and where is it useful? So these kind of things he will put a light on this particular topic. So.
Thank you once again. So there are questions about variant, how does it help? Before we discuss about that, I'll just show you one particular case about which we'll again subsequently discuss. This patient is a lady who came to me for a extended depth of focus lens. She had against the rule astigmatism of 0.48, and when I did optical biometry, so you can see that we chose, not visible. Right. So we chose eye-enhanced lens, and I thought putting a 21.5 or 22, keeping the patient slightly myopic, could solve the purpose. Until I decided to do a variant, and how I changed my plan we'll discuss after. We know what are the advantages of variant. Variant is an image-guided system which is intelligent. It helps in planning so that your refractive outcome is more accurate and reproducible. If we look into this graph, patients now expect too much because cataract is being termed as a refractive surgery. So this graph was given by Warren Hill. He said that more than 50% of our population here has a corneal astigmatism which is between 0.25 to 1 or 1.25. Now if you have that many patients who are coming to you with a corneal astigmatism of around 1.5, and you are not obviously telling them about a toric option, so are these patients going to land up into a neutral aspheric situation, or there is going to be a need for use of spectacles? The second graph shows from Warren Hill, where he says in the best of situation, your post-operative outcome would be 71%, where your lens refractive status will be less than 0.5. So you still have about 29% who will have a residual power of more than 0.5. So you cannot call refractive surgery as equivalent to cataract surgery. So this variant actually helps in differentiating what is a condition called as spherical equivalent versus a residual spherical power and a residual cylindrical power. A person might have a plus 0.75 sphere with minus 1.5 cylinder, and his equivalent becomes 0. So this is in true sense not correct. We have to segregate, and variant is derived from a term called veritas, which means truth in Latin. It is designed to decrease the variables in cataract surgery so that it improves the consistency in the surgical outcome. So where are the points where we can go wrong in our aim to achieve perfect visual outcome? It can start from a biometry error to a transcription error to a planning of astigmatism management error to marking of the astigmatic surface. Cycler rotation is another point where we often go wrong. Wrong SIA is one point. Smaller or larger capsular rhexis size and IOL placement, whether it is centered or decentered, and of course it also helps in optimizing your constant. So all these are required to have or to further improve or fine tune your outcome. This machine has two components, one which is kept in the pre-op area or in the diagnostic area, another which is kept in inside the OT. The pre-op unit is called as the reference unit. It has two parts.
So just one request. There is a Polo and a Mercedes in the parking lot. Dr. Vibhuti has to urgently leave for some urgent reasons. If someone can please go downstairs. And then again come back please. Huh? Yes, an emergency.
Yeah, so it has two parts. One is called a measurement module and another is called a vision planner. So what does the measurement module do? It acquires a high resolution color reference image of the eye. It also determines what is the corneal curvature, the limbus position, pupil size and corneal reflex, and stores them to be used for vision planner. So this is how it captures, and you get a screen like this where where in this corner you have some values written. It gives the limbus diameter, pupil diameter, curvature values and astigmatism power. And in the on the visual aspect of the cornea, it gives the steep and flat axis and pupil size and limbus size. The keratometry, it measures from 6.5 radius to 9.4 millimeter radius with the accuracy of 0.05 millimeter, which is in fact 34 to 56 diopters in diopter, and it has an accuracy in the axis to the tune of 2 degrees. Why the accuracy we call variant keratometry as very accurate is because it takes keratometry of a central 0.8 to 1.2 millimeter with the help of 3 IR LED lights, and these lights move to and fro, and it captures 900 images, and out of those 900 images it takes the central key. And there are a ring of 12 white LED lights which from which about 60 images are taken, and that gives the astigmatism. So because of that, it gives a more accurate K value than in comparison to the other optical biometers. The only thing is that because it takes in the center 0.8 to 1.2 millimeter, it requires some amount of A constant optimization. So variant reference unit also has a vision planner where it auto imports the information from whatever has been taken from the measurement module, and we feed in the other data like the axial length, the lens thickness, and then it gives us the option of choosing our lens, choosing our formula. It has a Barrett suite, holiday 1 and holiday 2 and other formulas. It also gives us advanced management system of astigmatism, either by selecting a toric IOL or by putting a limbal corneal relaxing incision or a clear corneal relaxing incision. So all these are planned based on a planner designed by Jack Holliday, and it is based on the algorithm of the nomogram found by Douglas Koch. Now coming to the unit which is placed inside, it is called as a digital marker, DMM. It has two parts, a screen and a MID which is attached to the microscope. The MID helps in capturing the live image of the eye. It tracks the eye and it also superimposes the calculated data onto the eyepiece. So it can be integrated both to Lensex and any microscope. So this is how, when you look at the screen, you get the name of the patient. Once you choose your patient, it gives you your incisions, side codes. It asks you where will be the location of the surgeon, whether it is temporal, superior, supratemporal. You can adjust capsular axis to the question that was asked. Capsular axis can be either pupil-centric or it can be limbal-centric. Most of us do it based on limbus because that is where you place the lens. Pupil-centric capsular axis actually might be slightly off-center when you place the lens. So this is another advantage. And the first step when you switch on the digital marker is that it registers the eye. After it registers, then it goes into the various steps. The first step is the incision guide. What happened? Why is it necessary to actually put your incision location? Is to actually avoid the intorsion of the eye. So if you, in this case, if you see that the steep axis is 135 degrees and if the eye intorts by 15 degrees, the steep axis rotates to 150 degrees. So if you are putting incision here, then you are actually not coming to the mark. So you need to pre-design your incision so that even if there is an intorsion, the marks on the variant also rotates, giving you the exact location of an incision. The other advantage of a markerless system is that in a marking, when you mark with a pen, the dots can be thick and it can off-center your axis by 5 to 7 degrees. It tends to fade over time. If you have a long list of surgeries, it fades. If you are using a cannula to mark, then the patient might get injured by a sudden jerky movement of the eyes. So these things can be avoided in a markerless system. Capsular axis, as we already discussed, it helps you to precisely size your incision, and it also helps to precisely put your toric lenses in place and align it. You have all seen in the surgeries how it is aligned. And lastly, you put your lens, you center your lens so that mostly in aspheric lenses or in toric lenses or even multifocals, if it is not centered well, the outcome is more disastrous. And last point is that it helps in documenting your results and helps you in optimizing your A constant and your SIA also. So this is a short video where you see that the patient is selected and it gives the on the screen where the surgery is to, how the incision is to be planned, and once you start it, then you get the this is a video recording from the screen, not from the microscope view. You can see here. So it gives you a fairly clear image, even though it's not through the microscope. I think these are all already done, so I don't need to waste my time showing you this. So you do this capsular axis, and this also gives the overlay of the Phaco machine. So that even if you are not looking at the Phaco screen, you can see what are your parameters of the Phaco machine on this screen. So I'll give you a few examples of how it helps. If you look at this particular patient, he has a cylinder of 0.76, and if you choose SRKT as the formula, you can see the patient has a spherical residual spherical power of 0.26 and a cylinder power of 0.56. So the net spherical equivalent is 0.02. Whereas if If you choose Barrett's, you can see the spherical power has increased to 0.38 and cylindrical power is 0.92, it's still more. And this patient obviously would not be a good patient to choose for a multifocal. You should go for toric. This was the patient I was talking to you about. Against the rule, studies of 0.48, and we decided to do eye hands in this patient. But when I put the patient into varium, I found that patient could land up with a spherical power of -0.84 with a cylinder of 0.73. So I decided to change the location of the incision and go superior. It further worsened. The spherical power became -1 and cylindrical power became +1. So here, what you should ideally do is try to go for paired arc incisions here, and it gives you that you have to do a paired arc size of 22 degrees at 9 degree and at 9 degrees, so that your net power becomes -0.14 with 0 cylinder. So this is one way where you can still go ahead with your surgery and avoid surprises, refractive surprises. Or you can go for a toric lens in these cases. Even though the power was only, the cylindrical power was only 0.48, still you require a toric lens in these patients. So these are some of the examples. I would probably skip that. To summarize, it helps you in giving you accurate keratometry, pupillometry, white to white, and a high definition image. It helps to plan it on a holiday platform or a Barrett's platform. It has a nomogram based on Robert Douglas clock. It has all the parameters to plan your torics, and it helps you to overlay all the parameters so that you do have a real-time digital assistance during your surgery to improve your outcome. Thank you.
Thank you so much, sir. Sorry I was out of doing the presentation, लेकिन ठीक है. एक होम जो भी आपने बताया, I would just like to ask कि ये feeling तो हमें नहीं है कि वेरियन नहीं है तो हम कुछ नहीं है. What is your take on that?
No, it's not that. My point is, many times we feel that somebody has a keratometric value of 0.5. We feel, okay, this patient is fine, we can go ahead and implant any lens. It's not true. So when you analyze that so variant is a machine where you superfine your outcomes. So you are likely to land up in some surprises if you do not have that. I would say still about 5%.
I mean, that question was that technically, is it worth investing that much to reduce that amount of percentage of practice?
It depends on your stage of practice.
This is the question I hope you were asking.
Yes. If you are in earlier
Any other queries?
practice, it is fine. But when you
question is, you are planning already order for optical biometer. If anyone going for the optical biometer, what will vary on this physical?
Sorry, I couldn't get you. If anybody has
for the optical biometer,
optical biometer is necessary in spite of you having a variant, because variant doesn't give you anything beyond K. It is a planner. It gives you accurate K. But all other parameters like your lens thickness, your antechamber depth, your axial length, all this has to be taken from your biometer. But with that, it will help you in planning out whether this patient is suitable for a premium lens or not. 30 odd lakhs, 33 lakhs, that's what they have supplied to me. I do not know.
Sir, as we are through COVID now and we know the ups and downs of private practice, so at what stage of private practice would you recommend the juniors to go to such a machine?
Well, if you look into the priorities, you should have a good microscope and a good machine. That is from day one. Then you upgrade to an optical biometer. That is when you have when you have surplus revenue to pay for that installment. That is purely dependent. I cannot say on that. And once you clear the dues of your optical biometer, you go in for a variant. Like I completed variant and now I went for your aberrometer. That's the next step. I went for aberrometer last this conference. market.
Thank you so much, sir, for elaborating these things in the topic. So thank you so much. So with this, we come to the end of this session, and now I request the panelists of the next session to please come on the dais. Thank you, Pandey sir, and thank you, Dr. Shivendra, Dr. Ashish, and Dr. Ritika for staying with us in the last session. I request Dr. J.G. Agarwal, Dr. Ranjana Kumar, Dr. Gyan Bhaskar, and Dr. Ashish Kedia to please come up on the dais for the panelists. Partha, are we ready from the OT, please? Yes, sir. So I think Dr. Partha is coming up for the surgery. He'll be operating one cataract and one LASIK. So can you come up with the patient details and all everything?
So, good afternoon all. The next patient is a 68-year-old female. We are going to operate the right eye of this patient. K1 value is 42.61 diopter at 98 degree, and the K2 is 44.37 diopter at 8 degree. Astigmatism is with variant 1.76 at 98. The axial length of the patient is 22.11, and the IOL we are going to do is 26.5 diopter panoptic toric. The other eye of the patient is faking. Over to Dr. Partha sir for starting the next session. Zero gravity, zero worrying with advanced toric. Sir, I would like to ask what does this really mean, zero gravity and zero worrying with advanced trifocal?
Okay, so we are going to use the Centurion machine and the active sentry. So the active sentry is a very, very important advancement in the technology that we have today with the Centurion machine. So what is so important about this active sentry is that irrigation has a sensor.
An invitation to you from our side right now. Please. So thank you so much, Dr. Rajesh, for your wonderful live surgery and the celebrations which you made. Thank you so much. May I now request SB Sahai sir to give the token of appreciation to Dr. Nagendra Prasad sir, who is missed out. Kahan hai sir? Missed out that time, so sir se milna tha, but this we really thank you for your spending your valuable time, your artistic surgery and your presentation. Thank you so much, sir. Sir, Dr. Partha, over to you, sir.
Okay, thank you very much. I think we have concluded the surgery. Thanks to the great OT team. Thanks to our patient. Oh, Jayagopal, that's a rare compliment from Dr. Jayagopal. Thank you very much. Thank you very much. So, any quick questions that we can yes.
When axis is centered, how can it control
With the what you said, when the nexus is extended, is it so? Okay, when the nexus gets extended, see, as you saw, my nexus was more like an amoeba than a round circular axis, despite having the use of varion. So it does happen with the fragile capsules that the control is not as good as with the taut capsule of a lesser mature cataract. So it tends to definitely waver off. But the moment, as you saw, that there was a tendency of wavering off and the Phaco. And then is the requirement of forceps, which you can go from either side, the left side or the right side, and then complete the rest. So the micro forceps is a very important tool in the armamentarium for every surgeon, and it should be used as a condition because the control that it gives is much better than the control that we have with the system.
Doctor, just one question. Why not use an access forcep in all cases instead of using the system? Because if you have a good control and using it every time, every case, that will give you a consistent control.
Yes, that is true, but again the access control, even the cystotome gives quite well. So our access forceps, again is a very delicate forceps. Usually each OP has 2 or 3 maximum, and you can use it, but again, it is swifter with the cystotome. And which basically I think all of us have grown up on the cystotome, so we tend to be a little cautious about discarding the cystotome which has got us on so many years now.
Partha, I think more important is that if you have to use a excess forceps, you have to use a high molecular viscoelastic because you do not want the wound to leak out.
Yeah.
In a cystotome, you can just go to the side code and do it, and it's much easier. Even if it's expensive, it is okay.
Quite true.
Any of the panelists, Dr. Ranjana, Dr. Gyan Bhaskar, would like to add something?
Sir, just wanted to ask that this was a patient with a 26 diopter lens. So in case of hypermetros, this was a standard calculation using a Baron tool. Do you cross-check if you're putting in a optic storing or something like that? Do you cross-check with any other formula while you are implanting such a lens?
See, again, 26.5 two of the things I would like to say is the Barrett formula works quite well with the 26 up to 27, it works quite well. Of course, you can use the Phaco also depending upon the calculation. Here we use the toric multifocal. Okay, so again a very good question. So should you use a toric multifocal? Yeah. Very important question, and I think it should be answered very, very well. So the first thing is the patient should want to have his reading without glasses and for distance, and the patient should want that he should get something better than what his first eye has already got. It is the want of the patient that should be a decision.
This is actually the modification of the anterior 2.2 millimeter of zone, central zone, and it actually doesn't split the vapor, but actually stretches the stretches the vision. That's why it gives the extended vision, and with the simpler kind of visual disturbances as in the monofocal, that is least amount of the night vision problem. So this art is very important while loading the lenses. Many times we become complacent once we finish surgery of this kind. We think that everything is over, but I have produced a lot of complications while implanting the lens. So particularly in premium lenses, you have to be very careful while loading, and I think I actually got some inkling that the lens folding was not that good, so you could have seen that it was folded in different ways.
Where we are concerned about these opacities in multifocals.
this is not actually multifocal extended range of vision, so least amount of the visual disturbances, and that too, you can see that opacity is there in the paracentral zone, in the central zone. So even if you do yard textotomy, you tend to do around 4 mm of capsulotomy, and this bump is there in the center, and the capsular thickening is actually beyond that. I'll do the IH part.
No, we were worried about the post-ER, the change in the ELP.
Oh, it doesn't matter much once there is fibrosis. So you do after 3 months, once it gets fibrosed. Because it is looking very floppy, the capsular bag. So I could have done some manipulation of that part with the CME hook. I have removed in some patients, but this patient I think is very floppy. If I do anything with that, maybe that there is PCR and I won't be able to put the lens. So I just didn't want to disturb. It is always very essential to remove all your scope from behind the lens. That's what I am doing here. See, there is so problem in the posterior capsule is actually traveling and it is stuck too much, so I don't want to disturb that.
Dr.Subhash, how do you calculate the lens power? What can optical diameter?
Yeah,
optical diameter is not possible.
Yeah, optical diameter is not, the immersion technique was used here. And I found that the immersion technique of this ultrasound with the machine which I have on scale is quite reliable. And see, that's why I'm not putting multifocal trifocal here. Extended depth of vision is this. Actually, even if you go little this side, that side, doesn't affect much.
One question I would like to ask Dr. Ashok Nanda also, whether he will go for a trifocal or a multifocal lens with the IOL calculation based on immersion technique?
Yes, I do. Only thing is that there's a
can you just to interrupt, can you see down here? Can you see a circle?
It's very clearly visible.
Yeah. So that's what I wanted to show you. Thank you so much. That finishes my surgery. I am doing the last part of visual, that is putting this data mouse into the anterior chamber. And I actually used to doing that and I've been doing for last, I think, 15 years.
Congratulations, sir.
Thank you.
Effortless surgery on a bad cataract.
Thank you so much. So now we will have LASIK demonstration by our star performer and the person who has the biggest or highest number of refractive surgery in the state of India, Dr.Partha Biswas. जब हम लोग नाम नहीं सुने थे refractive surgery तब से कर रहे हैं. ये हम लोग को LASIK दिखाएगा, then I will do one आगे and then the thing will be over. So
एक चीज पूछना था सर of your trifocal patients and readout patients, which is the most satisfied segment? How many which segment patients come back for refraction and which stay back?
And actually, if the patient wants that, I should have very good near vision and all range of vision, and if the patient is ready to accept little bit of visual disturbances, then the panoptic or trifocal is the choice. Particularly those patients who are not indulged in night driving, like you may say the retired person or the housewives, they are very much happy. But if the person who is actually young, I have nearly planted 40 Vivity lenses so far. Out of that, 10 is Toric Vivity, and I have chosen a patient, younger patient who are not into driving, and I have implanted Vivity in some professional doctors also, and they are so happy that they are operating without any glass, and in some of them bilateral. So Vivity actually. I was not convinced initially, and I said that I won't pay that much. I said to people that I'm not ready to pay that much of amount for a small thing. But once I started, I found that the result was really excellent and very good, and I am starting in 10 doctors, and out of them 8 are surgeons, and they are operating for very few days. So that's why I think that in those patients where they are ready to accept a little bit of near correction, say around, the people say that people say that since the defocus curve is such that it can actually correct up to 1.5, but I found that in my experience, nearly 50% of the patients they actually didn't require any near correction, and 50% patient required 1.5 to 1.25. That was the maximum 1.25. And in some patients I did some adjustment micromonovision. I over-corrected by 0.5 diopter in some, and these patients were really very much happy that said that दूसरा अक्सर तो नजदीक का थोड़ा और बढ़िया हो गया, ये हो गया, तो that is the thing I wanted to convey.
Sir, so do you suggest to keep target a little bit of myopia in Vivity?
Not exactly. In dominant eye, you keep it at metronomic power. In the non-dominant eye, try to give 0.5 diopter overcorrection. Unlike in other where sometimes you have to use you have to do overcorrection of -1 or -1.5. Here, just -0.5 diopter is sufficient, because the defocus curve is that it gives corrects almost 1.5 diopter on the near. So intermediate is very good. Near is little bit less. Thank you so much. Now we will have a 4 to 5 minutes of break. Reason being, the whole system is being shifted to Lasik room, and it requires this correction from the OT. So please hear and please discuss among yourselves. Thank you.
To answer Dr. Pranav's question about whether you should do a multifocal or not in a patient who has mature cataract or where optical diabetes is not possible. See, as a routine, we all know that when we are giving a multifocal or a trifocal lens to a patient, we have to increase our chair time. In addition to the chair time, we will also have a dictum that if a patient asks us more than 5 questions, he is not a suitable person. Now, in a multifocal, in a patient who has mature cataract, you cannot do a OCT. So, if you cannot do a OCT, you are not 100% sure about the posterior segment. So, doing a good biometry also doesn't solve the purpose. So, in these patients, I do make it a point that if a patient asks more than 3 questions after we explain about the pros and cons of doing a multifocal, not 5, then he is not a suitable candidate.
My question to you, sir. Being so many multifocal, EDOF, trifocal available in the market, does these lenses give you confidence to go for refractive lens exchange in presbyopic correct? Clear lens extraction with the IOP placement? Do you agree with me?
Well, this is an interesting question. Clear lens extraction or presbyopic, this thing is ideally done for people who have two scenarios. One is a high myop, okay, and they do not have lenses available because the lenses are usually available from 6 diopters onwards, or in some countries from 10 diopters onwards. So high myopes, you will not get multifocal or trifocal lenses many of the times. The second group of people where you can think of going for a refractive lens exchange are a group where the internal aberration is more. Their cataract is very minimal, but they do complain of significant amount of glare and halo in night time diving. So those are ideal candidates where you can go in for head-off lenses because they do not want glare. So otherwise, in a clear lens, you do not go for a multifocal or a trifocal lens, especially if it is involving a younger age where the demands for vision is much more.
Any comments from the panelists? Dr. Poddar, you have been operating so many cases and all these kind of cases. What is your approach? What sir suggested that his approach regarding the use of EDOFs and multifocals?
If you want to, what I decide in our case of multifocal eye, it's about the selection of the patient that is the most important. If the patient requires more of a near vision, then we go for a trifocal. And if patient requires more for intermediate or distance vision, then we go for a EDOF. And all kind of prerequisites for the patient, we should take into the account of any residual astigmatism. It's not the refractive astigmatism, rather the corneal astigmatism. The post-operative emetropia, the post-operative refractive error. That also gives a lot of trouble to the patient. And ocular surface disorder. So I believe that it's all about choosing the right kind of the patient. Those who are having the type A personality or they are very perfectionist, they are not a good candidate for a multifocal area. And as far as I have also seen the hyperopic patients do better, they do better with the multifocal rather than the myopic patients.
So I think what you wanted to point out is that patient selection is very important, I think. And hyperopic patients behave better because they have been using plus lenses for quite a long time. You want to give them, they are more comfortable if you are giving some kind of a trifocality or a EDOFs. So, Tiwari, you have been also running a very big center over here and people over there doing beautiful refractive cataract surgeries over there. So, what things you follow or what smaller things you keep in mind while counseling the patient?
Sir, while going for this extended depth and multifocal or trifocal lenses, there is one more indication. Keep the things simplified. जब पेशेंट आके बोलता है कि सर पैसा का कोई बात नहीं है, बेस्ट लगा दीजिए. फीमेल पेशेंट है तो पैनोप्टिक्स या पैनोप्टिक स्टोरिक, मेल पेशेंट है तो वीवीटी या वीवीटी स्टोरिक. और देखें हैं कि मोस्टली पेशेंट्स आर वेरी सेटिस्फाइड. In fact, I have few couple patients in whom the husband was implanted VVT and the wife was implanted panoptics and both are. But at the same time, if the female patient is gynecologist or actively operating surgeon, VVT lenses do fare better. In fact, some of the surgeons are very, very happy with VVT. But one more thing, that VVT is not completely free of glare and halos. Some of my patients who are very active and night and they drive themselves bilaterally VVT implanted and they are complaining about little bit of glare and halos. So we must maintain, we should not assure them completely that you will not get any kind of glare and halos. They do get. But of course, as compared to other trifocals, these lenses have a better acceptance in those all kind of night driving and active patients.
So these are the points which are coming. I think these are the interactions which we share because there are a plethora of IOLs available and which one to put becomes really a question in our mind. Every company comes up with their own things. So Dr. Nagendra, would you, before they start off with the next live surgery, would you just...
Hello? Dr. Nilesh, can you hear me?
Yes, sir.
Yeah, so you are just doing a Contoura Vision Lasik surgery. Dr.Partha will be performing one. I'll just share the results.
Sure. We'll come up with the discussion just after this.
This patient is 20 years female patient, very much motivated for going for removal of the glass. He has been wearing -2 diopters here on the right eye with -0.25 diopter cylinder with and the axis is 175 degree in the right eye. And the corneal thickness is 550 micro, pupil size, pupil size, and all are within acceptable limit. Just you will keep on communicating and when required I will also call.
Hello.
Phaco is also okay, it's not showing any problem.
After the modification, what we have arrived at is we are going to do a -2.25 with a 0.5 cylinder and at 160 degrees.
Just to show how much this patient had a higher order aberration, I am going back and putting 0 here. See, this is the different turning part. Here we have put -2.25 according to the nomogram and given some cylinder out of this. These are the actually patient acceptance, but the major cylinder was showing little higher with the difference in some axis, but the patient was accepting this. So we have taken some part of the cylinder here and not done any modification here. According to the nomogram, up to -2.25 we have to add -0.25. So now I am making 0 so that I can show that even when the power is kept at 0, the patient has some amount of And just to show you again, I am just changing it to the required one, minus 2.25, minus 2.25 sphere, and minus 0.5 and see this is the treatment profile, complete treatment profile. And if we go to the wavefront optimize of the same patient, if you want to do the wavefront optimize, this is actually the treatment planning which could be seen here. It is not correct in that other patient, but this topoguidal is creating some part of the, taking care of some part of the final. So now sir has applied the speculum.
आपको कैलकुलेट सीधा देखो अंजलि है ना, अंजलि सीधा देख के की ना तो बढ़िया से एकदम एक खराब व्यक्ति को याद आता है.
So the eye should be well exposed. Since everything was first that Dr.Partha may not be able to explain each and every step. Now the next part is. So we go for registration to this patient. You can see in this here you can see the eye. Now you put the IR down, the illumination ring down, which will actually register the patient eye, and that will take into account the cyclotorsion, and the patient has been worked up in topolizer. Should I move the IR?
Yes.
So the IR ring is moved down. Now you can see it has started tracking. Now I would initialize and move further. Yes, now this patient eye has been registered. You can see that there is 3 degree of cyclotorsion here. So even in some patients it can be up to 10 degree. So in those situations actually what happens that if you don't take into that account, the power correction may not be that accurate. So now I am putting the IR.
सीधा देखते रहो बेटा, लाइट को देखते रहो.
बीच में एक बार आपको प्रेशर जैसा देगा, लगेगा जैसे कुछ दबा रहा है, उसमें आपको कुछ सेकंड के लिए जितना टूट जाता है, डरना नहीं.
लाइट को कर सकता है. So we'll need 2 paracentral marks, and that is mandatory whenever we are using the SBK microkeratome. The microkeratome is very, very predictable, and we will preload the microkeratome.
He's testing the microkeratome forward pass and backward pass.
पानी देना हमको, पानी देना हमको. Now we have initiated the section. Normal.
Successful, sir.
अब जोर से आवाज आएगा बेटा, हिलना नहीं एकदम.
Now this is forward pass. This is backward pass. Now the flap is created. Flap has been created.
सीधा देखो बेटा. Wet copy. Wet. पानी. So the SBK microkeratome is a very, very sophisticated tool and gives excellent results. And some studies have shown that the results are as good as the consistent laser as well. So this is the plug that is done. So what is going to be most important is I don't want to laser ready enough. We will lift up the flap now, and the hydration of the flap has to be such that it should not be more than a very optimal hydration of the flap. So what I have done is I'm going to protect the hinge by the hinge itself. So that gives the hinge laser ready. So fix it. Cut it down.
Tracker is down now, it's tracking the eye.
और बच्चे को देखते रहना बेटा. और बच्चे को देखना है. और बच्चे को देखते रहेगी, आवाज आएगा, तब हिलना नहीं. रेडी हो. और बच्चे देखते रहेगी. और बच्चे देखते रहेगी. और
It's over. So the optical zone was 6.5 millimeter, ablation zone was 9 millimeter. Maximum ablated cornea was 46 micron.
So the washing of the bed is important, not too much. Just that much. See that patient is very, very cooperative. Wet stop. Wet. Enough. Enough is water. Close stop and enough. So with the wet stop, all that we need to do, this is a nasal flap that has been created, and Nagendra said that a nasal pinch is always a better pinch physiologically because it disturbs lesser of the corneal nerves. One small thing that I do is see the gutter, and the gutter has to be here. This is the gutter, and it should be equal in distance throughout. Now is something called the drying time, and the flap needs to be dried. At this point of time, we are also cognizant of the fact that it also dries the surface of the cornea. So place a small bubble of fluid, DSS, in the center of the pupillary area. So that gives hydration to the center of the pupil, whereas the edge where we want it to be dry as much as possible for the next 2 minutes, so that itself is dry. Whereas the central part, to which actually the patient wishes to see, is not dry. It is well hydrated. So this patient, after maybe in an hour or so, will get back quite good vision, despite an amount of drying that has taken place in the rest of the body. So this is a small trick that we use to have a patient more visually satisfied within hours. Wait for 2 minutes, and once 2 minutes is over, then only we let off the speculum, because this 2 minutes is very, very important, and the drying of the edge of the flap is what needs to get that. Of course, we have to tell our patients that not to rub the eyes and not to squeeze the eyes. Water putting inside the eye I usually allow after 2 days. कस के छीटा नहीं मारना है, ये हम बताते हैं. So अंजलि, आँख खोल कर रखिए, आप सीधा देखते रहिए. आज घर जा करके आँख आराम से बंद करके रखिएगा. आज जो है थोड़ा सा पानी आएगा, इरिटेशन होगा, थोड़ा दर्द भी हो सकता है. अगर दर्द होता है तो एनालिसिस ले सकते हैं. और कल से काफ़ी अच्छा दिखेगा, साफ दिखेगा और सब काम वगैरह सब कुछ कर सकती हैं, बाहर जा सकती हैं, टीवी, कंप्यूटर, लैपटॉप, मोबाइल सब कुछ यूज़ कर सकती हैं। ठीक है अंजलि? So this is the standard things that we tell our patients. और एक चीज़ ख्याल रखना है, कस के आँख मलना नहीं है 2 महीने तक। स्विमिंग अगर करती है तो स्विमिंग 2 महीने तक अवॉइड करना है और पानी दे सकती हैं आँख में 2 दिन बाद से, लेकिन बहुत जोर से पानी का छींटा नहीं मारना है। ठीक है? So I think 2 minutes have elapsed and we are stepping off the speculum. So a drop of antibiotic and proparoquine. आप खोल के रखना बेटा, रोज से खींचना नहीं। इसको या इसी को शिफ्ट कर देंगे। So we are shifting to the other eye. यदि आप खोल के रखेंगे बेटा, आप खोल के रखें। मुझको देखेंगे बेटा, हमारे तरफ देखते रहो।
So now other eye will be done. You can see here the refraction of the patient, and actually this is the patient acceptance -1.25 square only. But the total eye showed that she has got significant amount of cylinder also. So we are correcting some part of the cylinder. We are taking here in the final treatment plan. And I have decreased the, I have done the spherical equivalent correction when deducting -0.25. And as per the nomogram, we have to add -0.25 for smaller power correction. So the final correction will be -1.25 square and -0.5. And that's the cylinder and axis which was given by total iron is 2D. So we have kept 2D. Again here we will make 0, then you can see the difference. 0, you can see this is the higher order aberration which still remains even if you correct it completely. So that part is taken care of your ophthalmologist.
ऐसा ही रहेगा, आवाज आएगा, बहुत सीधा करके तो हरावती दिखा जाता है। एकदम आराम से So again, going back to basics, why a paracentral mark? Because a paracentral mark is what is going to give the alignment of the flap or a cap whenever it is required. So it should be paracentral. And this is one step that no one should shortcut into a classic. See that it थोड़ा सा दबाव पड़ेगा बेटा, हिलना नहीं है।
Now the activation of eyes
जोर से आवाज आएगा, मुझे हिलना नहीं बेटा।
forward pass, the speaking microkeratome backward pass. It creates 90 background flap. Some of you must have noticed +2 written over the wing. Actually the that the size of the ring is decided by the keratometry value of the cornea. So that you not end up in the problem of either free cap or button holding. So that is also very important to look upon. And while applying the friction ring, there is a small lock that also has to be taken care of. In the earlier one case, in the very beginning, I did a mistake and then I ended up with partial spectacular. So that is it. Machine is still not recognizing the pupil because so once the pupil size corresponds with the examination size, yeah, now it is registered.
Sir, any special precaution in protecting the hinge?
Yeah. So as you saw that the hinge are protecting with the flap itself.
You can use aerosol sponge actually if you think that it can, particularly when the horizontal axis is horizontal cylinder, or you can say that when you expect that the horizontal part will be ablated more, like horizontal cylinder, it needs to be protected. Pupil is centered. So surgery over, it has ablated 9 micron, 29 micron. The surgical time was 5 seconds. No matter how many cases you have done, but once you see the surgery of masters, you always learn something, and I have also learned something from him. That's why I wanted to keep on Lasik for him. And there are some final nuances which every time whenever you learn or see any surgeon, good surgeon performing, you always take away some message or some tips. And I have learned some tips from Dr.Partha. So thank you very much, sir, for agreeing. This was not actually included in agenda, but I requested him, sir, एक Lasik आप ये रखें करेंगे, जो भी करेंगे, बस यही है कि आप बहुत अच्छा demonstrate किया हम लोग को. I'm so grateful to him.
One question, sir. While depositing the flap, should we, in the beginning, make a mark so that there is no torsional effect or by mistake or something? Can we do that, or is it not required?
Yeah, it is actually the marker itself will provide you a good assessment, and the next thing is the gutter. So the gutter itself another is a good assessment of.
So just wanted to ask that if you're doing a wafer guided and a customized topographic guided ablation in one eye, is there a difference in the thickness of the corneal stroma that is ablated? Significant difference?
Yeah, we take into account during my talk I showed you how much extra amount are we going to take off during the application of the higher order. So in that patient which had minus
guided Lasik. So I think the post-op medication, sir, could you just before it starts, sir, what would be the protocol? Immediately after, sir, can you keep the mic closer, sir?
Okay. Immediately after, we put a drop of Panatin for both the eyes, and that is for the post-operative meal that the patient is going to have. And then I'll just take twice a day, Calpol 650 or something.
the surface ablation in this patient, and I do the trans-epithelial. So I'll just ablate the epithelium first. There are various ways of removing the epithelium. You can use 20% ethyl alcohol, you can just mechanically stretch it, or you can use amylase pressure. But here with PTK mode, we can just remove the epithelium. You can so the laser is being fired and it will remove the epithelium which is around 50 micron. Once that epithelium is removed, then we will go into the other mode of correcting the refractive error. So the epithelium is removed. So it's changing the mode now. Putting the tracker down, you can see the epithelium, which the part which has been removed. And now the eye will be restored. The same process of eye restoration. You can see here there is cycle rotation of 6.5 millimeter actually. 6.5 degree. Now I will do the focal guided ablation of this patient. Power is just minus 1.25 and 0.5. Now the another important step is to put mitomycin. Depending on the amount of power, we put it for 10 seconds for one diaper. So I will apply it for 10 seconds so that there is less chances of hit. This is not that much important in small power, but for higher degree of power, you actually need to apply it for longer period. And of course, we have the patient who wear UV blocker glasses for at least 1.5 to 2 months. We will use steroid little longer here along with vitamin C. Vitamin C tablet. One has to thoroughly wash the remnant part of the mitomycin. And then we apply a contact lens over here. The initial bandage contact lens is applied over here. So this part is over. Just put one antibiotic drop. Draw that one. Since he had only power in the right eye, so I am operating on the right eye. Left eye is hematotic, so I am not going to do anything. So this finishes the Lasik part or refractive surgery part also. So we are done with all the live surgery, all the talks. So I would request Mrs. Prasad, there, Director of the Ministry Eye Center, to formally request you all for lunch. Sorry.
Thank you so much.
So thank you the office staff and everyone. It was a really wonderful.
इसी के साथ हम आज क्या ये कार्यक्रम समाप्त करते हैं। मैं बाहर से आई गेस्ट फैकल्टीज और यहाँ के मौजूद डॉक्टरों को दिल से आभारी हूँ। आज के समारोह को सफल बनाने के लिए आप सभी को तहे दिल से शुक्रिया। प्लीज ज्वाइन हमें लंच के लिए करें। धन्यवाद।
Feeling.